The world of geopolitics is complex. It encapsulates foreign policy, defense, trade, and culture. These can have ripples that can be felt all around the planet.
With that, we welcome you to The Global Detail, a podcast where we go beyond borders and behind the headlines to stories that impact the world.
Our goal is to peel the onion and explore the various diverse layers through riveting interviews with experts and stalwarts. I'm Akshobh Giridharadas.
And co-piloting this journey, I'm Brendan Duke. Let's get into it. To be a free-range humanitarian is to be a fish forever swimming against the tides of human apathy and avarice. All around the world, from the Americas to Europe to the Middle East and Africa, politics is an inescapable fact of life. Unfortunately, it is one that stands in the way of good people like those at Médecins sans Frontières, known to the English-speaking world as Doctors Without Borders, often called MSF for short. The humanitarian organization was founded in 1971 by a group of French doctors and journalists in the aftermath of the Nigerian Civil War. Their mission was to help people regardless of race, religion, creed, or political affiliation, wherever they were in need. In 1999, the group was awarded the Nobel Peace Prize. Dr. Unni Karunakara is an India-born physician who was the international president of MSF from 2010 to 2013. These days, he is a senior fellow at the Global Health Justice Partnership at Yale University. The Global Detail spoke with Dr. Karunakara about the work of MSF and the obstacles they face in the course of their ongoing mission.
MSF has been around for 5 decades or so, if I'm not mistaken, and you traverse borders. Your whole identity of MSF is Doctors Without Borders, avoiding the geopolitical narrative of countries and keeping equality at its center. And you go into places which has armed conflicts, hit by natural disasters, and just providing at a kernel level basic access to healthcare to some of the most vulnerable populations. At its core, is altruism what drives MSF? How would you describe what keeps MSF going for someone, you've been there for so long? What is the secret sauce of MSF?
As you said, Médecins Sans Frontières more than 50 years old. And what drives most MSFers today is a core belief that people should not have to suffer the consequences of political violence, natural disasters, etc. So in some sense, what it does is it points to failures at several different levels. There could be political failure, it could be systemic failure, but people are very often suffering for no fault of their own. And MSFers believe that extending a helping hand when people are most down and out is the humane thing to do. So it's at its core, it's the principle of humanity that really drives the organization.
Right. Well, right now we are at a time where a couple of years ago, we would never look at healthcare as a geopolitical crisis, but in the last 2.5 years, a single microbe, where we looked at threats in terms of nuclear weapons and ICBM, but we talk about a single microbe that has had cataclysmic collapse of economies of our healthcare systems. And for the first time in a long time, all the countries in the world, whether in the global north or the global south, are facing the same issue. That is, one healthcare issue has become an economic issue. It's become a national security issue. It's become an issue between the haves and have-nots in all countries. Has this brought in the healthcare debate to the forefronts of government tables as compared to just being an insular national issue? It's become a global issue the way the climate has in the last few years.
Well, health has been a global issue far longer than climate change has been. If you go back to the 90s and the early noughties, global health, we call it the golden decade for global health. There's a lot of money pouring in. There's a lot of goodwill. Countries like even George Bush, he's credited for providing huge support for people suffering HIV/AIDS from HIV/AIDS in the continent of Africa, etc. So global health has been it's sort of the first big global issue that I have had to deal with in my career. Climate change, of course, it's now the issue du jour, and hopefully there will be some concrete action. But I think even climate change can learn a lot from the ups and downs of global health, and pandemic being a clear illustration of what can happen. Yeah. So there is in global health, global solidarity was the solidarity between nations, WHO being a UN body which has a norm-setting role, bringing countries together, setting standards, etc. And what we've seen in this pandemic is a total collapse of global governance and global solidarity, which is very worrying. But health itself as a global issue is not a new thing. We've been concerned, those who've been following public health have been concerned about precisely such an event. It's been talked about and prepared for, but obviously the scale of what has happened in the last few years has taken everybody by surprise. And even more surprising is the total collapse of countries not being able to come together, even at the worst moment we are in as a planet. We haven't been able to come together and address it together. So that's been disappointing, greatly disappointing.
That brings up a few questions, because one of the things the pandemic has done is it accentuated, or rather exacerbated, the gaps that we already have. We say the gap between the haves and the have-nots, but facetiously at times you'd like to say the gap between the jabs and the jab-nots. We talk about vaccine equality. We saw the need for affordable vaccine and last mile delivery becoming a problem, particularly countries in the global south, where the access to affordable healthcare has always been an issue, but the vaccine delivery, and we talked about how logistics and because supply chain issues were disrupted, just the ability to get affordable vaccines. And there are still countries where a lot of people haven't been vaccinated, or perhaps still behind on some of the vaccinations. What are MSF's priorities right now as we try to battle the COVID-19 pandemic and different variants come out, and in terms of vaccine delivery and vaccine affordability?
So delivery of vaccines is largely the responsibility of states and its ability to get vaccines from international facilities that have been set up. International facilities like COVAX has struggled to fulfill its commitments. So countries in Africa have had to source their vaccines from countries like China, Russia, etc. So that's been. I would argue that that what we have seen. So, for example, if you compared it to the Ebola outbreak. And we've always had this narrative that health systems don't function because countries don't have resources, they're not prepared. So it's not surprising that health systems fail. But what has been really a revelation in this pandemic is how spectacularly rich country health systems dysfunctioned. So if you're looking at rich countries like the United Kingdom, United States, etc., they faltered. They faltered in the beginning for all sorts of reasons. It could be political, it could be lack of preparedness, etc. But what we saw, what the world saw, is rich country health systems unable to cope with a pandemic of this size. So, and that has been a total revelation. So MSF has been caught in the middle of having to sort of be in between, to some extent, between the country, we deal with two kinds of access problems. One, of course, is accessing the populations that are going through in humanitarian crises, going through a very difficult time. The other thing, of course, is the other access problem is, of course, being able to get the right medicines, tools, etc., to the people who most need it. So
Right.
this has been something that we've been working on, and sort of trying to fill in the gaps in the countries where we work.
Right. I mean, of course, the pandemic, as you said, has put healthcare and treatment at the center of people's attention. And one of the things I think MSF has put out is the need of the hour is to develop sort of community-based, patient-centered healthcare models, particularly for disease monitoring. Could you just talk us through this? What does MSF have in mind? Is it sort of prevention better than cure, looking for the long term? Where do we see the fissures in our healthcare problems?
Well, health has to be approached in a multifaceted way at all times. It's never just working on prevention or never just working on cure. It has to be that whole spectrum of activities that we need to engage in at any given time. So pandemic is no exception. Right. Of course, we are concerned with how do you prevent people from getting infected in the first place. But of course, there is a whole, once you sort of address that, or once you sort of engage in that, you can't get away from the fact that there are people with a higher susceptibility. There are people with existing conditions who are more vulnerable than others, and you cannot just say we only do prevention. So we have been sort of engaged in providing expert care for people who have contracted COVID. But then, of course, you have to keep in mind the mental health consequences of living in lockdown, being isolated. And in India, for example, we even started a mental health hotline for people to call in, whether it's to just get COVID advice, but also for coping with isolation, living in lockdown, other social concerns. So it has to be a multifaceted approach. It can never be prevention alone, it can never be cure alone. And you have to, and a pandemic of this nature has huge social and economic consequences as well, which cannot be ignored. And all of that somehow comes together in public health, and that's something that we are increasingly sort of engaging in and sort of trying to do our best in countries where we work. But curiously, it was not just in some of the. There was some in Spain, for example, and I can't remember all of the countries, but in one or two other European countries as well, MSF responded because there were gaps, because the systems could not meet the needs of all the people that needed care. So it has been a learning experience for us as well.
One of the things that the healthcare professionals and healthcare communities, such as yourselves, would have faced in the last 2.5 years was on the communication side as well, because there was a lot of disinformation, particularly on vaccines, and the need to both enlighten the global community on vaccination, but also countering disinformation. We've seen disinformation not just a political tool, but it affected professions like yourselves. What is sort of your communications? How are you thinking about healthcare from a communication standpoint right now, particularly in the era when there was so much vaccine misinformation and disinformation going around, because that disinformation does end up becoming a healthcare crisis as well?
Yeah. Trust is a complicated issue. I think there's been some evidence that countries where the people have a high level of trust in their elected authorities did very well with information than countries that did not have that kind of trust. right? So it is not just merely the stating of medical facts that engenders trust. It's also who is delivering that message, right? And one thing that has been clear is that in times of pandemic and in times of public health crises, messages have to be delivered by people who have that trust of the people. And sometimes it's a politician. In Kerala, for example, they created a committee of public individuals who had high levels of trust in the community to be able to formulate the message and to deliver it. So it is not just a question of writing a fact sheet and sending it out. And also, this anti-vax movement, which used to be sort of a California thing, is now gone global. It's really, really spread like wildfire, and that I think is also found. It's like the political environment was a nice little petri dish in which all of these conspiracy theories and misinformation could just grow. Affect the social fabric. So we've had to deal with that problem as well. Now, the solution for this, by and large, has to be really local. So you have to engage with local communities. You have to find a way to respond to fake news as and when it comes up. There's some really interesting experiments of using WhatsApp to fact check, WhatsApp to counter misinformation, etc. But of course, a lot of it is, you have to realize it's not just people just worrying and sort of sending messages. There's also some deliberate mischief, I think, created by certain parties with not so much good faith. So, yeah, it's not just a question of writing a fact sheet. There's much more to it in communicating in times of pandemic and about pandemic.
I mean, what I've always found fascinating about MSF is you're not just a healthcare humanitarian organization, because of the complexities of the areas and the issues you deal with. You're simultaneously dealing with, healthcare is not an isolated issue alone. The areas you deal with likely has a food crisis, famine crisis. It's affected by climate change. There's extreme poverty that we're dealing with. Of course, those areas do have a lot of political instability, and the malnutrition aspect of the healthcare comes in, and civil unrest. How do you operate factoring in all these disaster-prone scenarios? Because it's not so much just having medical professionals, but you also have to have people who are adept at dealing with complex humanitarian issues, such as these various ones that are listed. How does MSF have a 360-degree approach of dealing with some of the hardest issues that we've known to global humanity?
Yeah. So, when you talk about a virus or a bacteria, it could be tuberculosis or it could be a parasitic disease like sleeping sickness. Of course, there are these biomedical aspects of a particular disease. But very often, not very often, you have to necessarily place it in its social context, its economic context, its political, environmental, legal context to fully understand why it affects the people it affects. Very often we are dealing with the poorest of the poor people. Even in poor countries, the disease affects the poorest people. So there are multiple levels of injustice and inequity that we deal with in that we see and we have to address while delivering assistance. Like I said earlier, that there are two kinds of access issues that we contend with on a daily basis. One is just the fact to get to the people who are in need of assistance. And we have this principle of impartiality, that our only consideration for delivering assistance is need. It's not race, religion, other political considerations. It's need. But even to get to those individuals or communities or populations that need assistance is not an easy thing. We are without borders, Doctors Without Borders, but we have to contend with borders every single day. Because it's not like we can walk across a border and start delivering assistance. So it requires patience, it requires lots of negotiations, and it requires maneuvering through sometimes a political minefield and to get to those people. Once you get to those people, of course, do we have the right medicines? Do we have the right vaccines? Do we have the right tools to provide the best possible care? And very often we don't. And we've seen that with the early days of the HIV/AIDS epidemic, where poor people are often priced out of the market. They're unable to buy medicines that they need, life-saving medicines, which are easily available in other parts of the world, are either unavailable or not the right ones that people in the countries where we work need. So there are multiple factors that we need to, multiple levels of injustice and inequity that we need to contend with in delivering our assistance.
More specifically, in the last year alone, on the geopolitical side, you've dealt with conflicts in Afghanistan, the massive humanitarian exodus, and of course, the crisis that we still have right now in Ukraine and Eastern Europe. These are massive, complex humanitarian issues. And one thing I think MSF and Doctors Without Borders perhaps need to get more credit for, apart from providing the healthcare and emergency needs, is also putting their own lives in the value of these conflict zones, because a bullet distinguishes no one once it's shot from a barrel of a gun. And I think these crises in the last 2 years alone, how has MSF adapted to this, or how is MSF dealing with these current complexities as we speak, because we're not out of the woods yet in either Afghanistan or Ukraine?
Yeah. MSF has a long history in Afghanistan, and at one point in the 80s and the 90s, we were the largest humanitarian agency in the country, providing healthcare in almost all of the districts in the country. And of course, now it's a very different situation. And negotiating for access has always been a reality for humanitarian organizations, including MSF in its 50 years. But of course, that job is a bit harder. For me, I come from India. I'm not a Christian. I'm not Jewish. But yet, very often when I represent the organization, I'm seen as representing Judeo-Christian, sort of liberal,
Western,
free market, Western sort of ideology to people who have very different visions of how to construct their lives, how to construct their communities, etc. We may not agree with it, but that's a reality. And a lot of the tensions that we see are these clash of isms, liberalism clashing with Islamism, liberalism clashing with socialism, etc., right? So these isms clash, and of course, people are caught in between the struggle, and people are often, the ones to bear the consequences of these clashes and these conflicts. Now, we try our best to, whether it's in Afghanistan or whether it's in Ukraine, we try to focus and you talked about context being very complicated, but even in complicated contexts, I think the best way to deal with it is to be focused on the need and the people who are in need. Now, even with that, I mean, it's easy to say just focus on the need and focus on the people. But one thing that we see all over the world is states that are increasingly closing the space for civil society action. So a country like India, you can call it a liberal democracy or an illiberal democracy. depending on how you see it, or you can have a one-party state like China, or you have an authoritarian state like Russia. To my mind, the tendency of the state is the same. Regardless of the nature of the state, the tendency is somewhat the same. They tend to limit civil society action. And in many of these countries, the only way you can operate, or that space you have to operate, is either you keep quiet and provide assistance, because any criticism of what's going on around you might lead to one or two things. One is it might lead to insecurity, which you sort of alluded to earlier. And second, you might actually get thrown out of the country, right? Either of which is okay. I mean, we can just walk out. But of course, it's the people that'll go without care. Or people who are caught in the conflict will have no assistance whatsoever. So that's always the dilemma that we are faced with. And the other side of the coin is that you buy into the state's narrative about what the problems are, how they see humanitarian action, how they see development, etc. Once you buy into that narrative, you also run the risk of then being a mere service provider. The government will point you in the direction, we want you to provide aid there, we want you to provide aid there, and then you become sort of instrumentalized very often by states who have vested interest in providing assistance to certain populations and perhaps not others. So these are all risks that you run, and the one way that we sort of keep our focus is to focus on the principles. Now, principles, of course, we have 4 principles: humanity, impartiality, independence, and neutrality. Now, these principles help guide us, but we also know that the delivery of humanitarian assistance is a daily sort of a balancing act between being principled and being sort of practical. So we make compromises all the time, because ultimately it's more important than your principles are the fact that people need to receive assistance. So that's uppermost in our mind at all times. That's how we sort of maneuver, or how we sort of are able to deliver assistance to people in countries like Ukraine and Afghanistan.
Your point right now on perception and perhaps the way MSF may be perceived by people who have preconceived notions took me down an interesting path. Back in the day, in the 1960s, when under the Kennedy administration, when Peace Corps and Fulbright became a very central part of U.S. foreign policy. Well, partly it was soft power. It was time of Cold War, two competing blocs, this narrative between capitalism and communism. And Peace Corps at its very kernel level had a sense of altruism, of sending young students to some of the more impoverished parts of the world that MSF has good experience in. There was also a perception that there were people who were part of the intelligence and, CIA infiltration in some of this. And NGOs always have that. And we've seen that even in countries which had a record of welcoming NGOs, suddenly throw out certain NGOs, assuming they're up to, serving a higher cause. I suppose the one thing I would ask is, how does, but also while this happened, on the other hand, the Dalai Lama once said, Peace Corps was the best example of US soft power. Would you say MSF has been a good example of French soft power as a France founded organization, but I think Geneva headquarters? And the second part is there that sense of constantly trying to repurpose the narrative as, altruism is our credo, as you rightly said, there's impartiality, and constantly having to work with authoritarian governments to, that does serve as constant blockades and probably the biggest challenge for MSF.
Yeah. So there are a lot of things to unpack there. Altruism. I think it's a bit deeper than that. I think people are, we say that we are an apolitical organization, but the moment you decide to intervene somewhere, it is a political act of some kind. You're saying that something's not working here. That's so that in itself is a political act. Whether you say that, I'm going to provide assistance in South Sudan, and then suddenly after Sandy Hook in New York, was it Sandy Hook in New York?
I think Connecticut.
Yeah, so, intervening there is again a statement that something is not working as it should. So there is that political. Now, yes, we are impartial. We don't take sides in terms of, we are neutral. We don't take sides in a conflict, but we are never neutral to the suffering of people. We are constantly taking the side of people over state, because in many of the places where we work, we cannot rely, or we haven't been able to rely on the state to act in the best interests of the people. Now, this might be seen in today's world as people coming from the West and telling them how to run affairs in Africa or in Asia or in Latin America. But that's not what I mean. If the bigger question is, are states the best, are always representatives of the people in their countries? For some people, yes. At different times in history, governments represent some of the people, maybe not all of the people. Now, in a democracy, well, even if it's not functioning to the fullest extent, you can say that, well, okay, by and large, an elected government represents the interests of the people who voted for it and who did not vote for it. But in some countries, it gets even darker. That certain minorities or certain groups are systematically excluded from services. Their rights are suspended. So, for example, the Rohingya population in Myanmar. And there are many such examples, unfortunately, in other parts of the world as well. So, working with governments, for example, in the natural disasters, very often the interests align for a brief moment. The interests of humanitarian agencies and governments align, and it makes eminent sense to coordinate with national authorities and provide assistance to people who need it, right? Because at that time, the governments want to reach everybody. But let's say in a country like Afghanistan today, even before the Taliban, when the Americans, the NATO forces were running the country, at best, it had control over 50% of the landmass of Afghanistan, right? So you cannot claim that they represent all of the people. So these are things these are contextual issues that we need to be aware of, and we need to sort of engage with while providing assistance. So especially working in a remote area, the best approach would be to work as local as possible with local power structures, local authorities, etc., to deliver assistance. But that might not always sort of get you the best outcome. So we talk about humanitarian assistance in South Sudan, for example, and we've been present in the country for 30, 35 years now. Yet there is not a government structure strong enough to set priorities, take ownership of the priorities, and meet the needs of people, whether it's health, whether it's education, and also to secure the population. Right? And I'm not just talking about border security. I'm talking about health security, nutrition security, environmental security, etc., etc. So this, I think, global solidarity and humanitarian action, I think, unfortunately, is something that we will have to live with, and we will have to. And I take all the criticism that comes that overseas assistance and humanitarian action, and of course it needs to be localized, etc. But I think there is a value in societies, disconnected societies, because societies that from different parts of the world come together to address problems together. This is civil society action, right? This is not action that is guided by countries or nations, etc. These are people standing together with people. So that's the idea that I find powerful. But of course, you could argue that people talk about the development industrial complex and the humanitarian industrial complex. We're talking about billions of dollars that are raised and spent every year. So that's also a reality that we have to contend with.
Yeah, that gives me a good segue to speak about the evolutions of healthcare right now. Particularly for an organization like yourselves that have been around for a little over 5 decades, evolution and innovation is sort of, common across all sectors, and yours is no exception. Particularly now in the field of medicine right now, we're talking about delivery, emergency, and delivery in terms of drone technology for the most dilapidated areas and that have humanitarian crisis. How has MSF adopted to the new evolutions of medtech, and particularly drone technology, which has made its appearance in delivery in last mile, especially for last mile delivery in terms of in some of the areas that are hit by floods and famines, and just has it really enabled and helped MSF be able to get across to and aided you in ways that you would not have been able to 40 years ago?
So before I go into innovation, just briefly want to touch on drones. Drones are sensitive. It's a sensitive technology. You have to imagine that we were just talking about Afghanistan. The people of Afghanistan associate drones in a very particular way, because it is a weapon of destruction. It kills, it maims. So drones are not the right sort of technology that we would sort of adopt in very sensitive areas like that, because it really comes with baggage of being a weapon of destruction. Right? Now, how are we as a humanitarian organization how do we continue to be relevant in the coming years when it's not just, we're talking about global health issues, we're talking about climate change, and how can we stay relevant in the future? And also, we're living in an age where Black Lives Matter, decolonization of health, all of these are necessary discussions that are ongoing at the moment. All of this is going to change humanitarian action, I think, significantly in the coming years. So there's already quite some discussion about localization of assistance, that people in the countries where disaster has taken place, or in many such places, people are the first responders, and there's no doubt about that. And as such, they should be given access to a lot of the funds, so that they can first of all take care of as first responders, meet needs, but also over time put in place systems and processes that will help them be resilient and deal with such disasters in a better way in the future. Now, if you look many countries who've suffered many disasters historically. Bangladesh is a good example. Indonesia is another example. You can see that over the years, they have been very good at learning lessons, putting the right sort of measures in place, and then next time disaster hits, they're better able to respond, reduce mortality, recover faster, save lives and livelihoods, etc. So there are many good examples of countries learning from disasters and putting good systems in place. On the other hand, you have countries like Haiti can never seem to get a break. They are hit constantly, and they hit at a regularity that does not even give them space to build systems. And they have other social issues also to deal with, right? So in these sort of, we are looking at whether we need to change our operational model. So, for example, the first 40 years, MSF received money from rich countries, and they spent it in countries where we had projects and where we had engagement with communities, etc. That has changed dramatically in the last 10, 15 years. We are now talking about countries at once being in need, but at the same time being a place with immense resources. India is a good example, right? Yeah. India has needs, one of the highest malnutrition rates in the world, but at the same time, it has scientific capital, it has huge financial capital and human resources that MSF can use to help people in other countries. A doctor or a surgeon coming from Boston is less likely to have seen some of the cases that he or she would encounter on the ground. An Indian surgeon might better be suited for a condition like that. But more importantly, we are also going beyond that, right? To see, well, there's a Congolese surgeon, perhaps. So one of the things that MSF has done is to create a fund, which is called the Transformational Investment Capacity Fund, looking at ways we can transform humanitarian action. So one such project is training nurses and surgeons in Africa, and African nurses and surgeons are trained in African hospitals, but in building their skills so that they can better respond. They can be first responders, but they can also better respond to other needs that exist in the country. So that's just one example. Technology is also something that we are looking at. Are there tools that we can use to prevent child mortality, maternal mortality, manage supplies better, telecommunication that might help managing security better, for example. So there are many examples or many such projects that we are looking at the moment to see how, as an organization, and what I said earlier, perhaps a new operational model, maybe working in partnership rather than parachuting in, providing care assistance and then leaving, right? So working in partnership is unfortunately not something that MSF is. They have worked in some countries really well, but as an organization that comes in, MSF also has a reputation sometimes of being, the cowboys. They come in and I have to say that we still learning how to partner well with local organizations. And partnering means that, sitting around a table, having discussions, and maybe the priorities that we end up are not the ones that you thought or we thought we would be working on, right? And to cede that control is a very difficult thing, especially when you come with resources, when you come with that ceding control to local actors and local partners has been a very difficult thing for MSF. But this is something that we are trying to do better. We're working sort of very hard to try different ways of, and so person-centered care, community engagement, all of these are responses to our commitment to sort of work in partnership with communities and individuals on the ground. And it's a work in progress.
Right. I suppose you may have answered my next question, but I will have to ask you to expand a little bit on it, because one of the challenges I foresee for MSF and for a lot of other non-governmental organization, not-for-profit organization, has been dealing with a bureaucracy, as you've already said, and dealing with very authoritarian governments sometimes, but just a bureaucratic process with other governments and perhaps intra-agencies, other organizations such as the World Bank and the United Nations, which operate in areas that you operate in. What sort of collaboration, if that's a key word here, have you been able to foster, and perhaps the conundrums to those collaborations? And I think the last point to this question I'd have to say is the elephant in the room would have to be big pharma, because as we've seen with big oil and big tech, big pharma would fill that pillar of that precludes accessibility to affordable healthcare and medicines. Everything that MSF is about, affordability of healthcare, and I think big pharma is on the other end of that spectrum. So perhaps if I'm asking to fill in the collaboration puzzle, how would that work out?
Yeah. Two big questions here. Now, let's look at bureaucracy first. To my mind, there are three bureaucratic walls that we hit on constantly. One is the state. So we have no way around negotiating with states and working with states. Now here I have to, for example, and very often military, which is sort of the extension of the state, which has a legitimate sort of mandate to secure borders and the safety of people in many of the places where we work. Now, in a country like Haiti, when the earthquake happened, lives were lost. The U.S. sent a naval vessel which was docked outside Port-au-Prince, and we used to send some of our patients for whom we could not provide care to the naval vessel which had higher capacity, ability to carry out surgeries that we were not able to. So here you work with the military because the military itself is not in a belligerent mode. It's there as a humanitarian actor. Right? So here we are able to work with them. Similarly, but in Afghanistan, there was never that space to engage with states or engage with military, because it was clear that the military, the foreign military, were there as belligerents. And our neutrality will not allow us to work with parties, military and other authorities that are party to war. Right? So here the distinction is very clear. On Haiti, it's a humanitarian actor. In Afghanistan, it's a belligerent actor. But then what do you do in countries like Pakistan, where you're constantly dealing with the military in the border areas, where the role of the military is not always clear, but you stay away because being seen with the military, you are not you may not be seen as a neutral actor. But at the same time, there's an earthquake in a remote part of Pakistan, and if military is the only agency that has the heavy lifting capacity to carry tools and medicines to faraway parts of very remote parts of the country, mountainous parts of the country, then do you work with them or not? So these are dilemmas that we face with. And in addition to what I said earlier about states and how they try to limit, as a general tendency to limit humanitarian acts. So that's one bureaucratic wall that we have to deal with. That is, and there's a constant attempt from the state and the military to co-opt humanitarian action, either to help them or to sort of do their bidding in some sort of way. Second bureaucratic wall is, of course, one you alluded to. It's the interagency, UN bureaucracy, and all of the different humanitarian actors that are present today. What we've seen in the last 20, 30 years or so is a proliferation of humanitarian actors. So MSF and maybe ICRC or maybe one or two other organizations might talk about humanitarian principles, etc., but it is very difficult for anyone to gauge the intentions and motivations of the hundreds of humanitarian actors on the ground today. Right? So you can imagine that the proliferation itself sort of muddies the ground a little bit, and then coordinating between different agencies of different capacities, different principles, different motivations. And with UN, at some point, they're supposed to be a neutral body, but we also know that the UN does the bidding of the Security Council of the five actors who are anything but neutral when it comes to conflict in any part of the world. That's one bureaucrat. So the third bureaucratic wall is internal. An organization now with roughly $2 billion annually, with about 50,000 people around the world providing assistance. And then, it might be more than 50,000, but you can imagine the kind of bureaucracy that creeps up, and suddenly you're a middle-aged organization and you don't often recognize yourself because everything needs paperwork, everything needs, So the internal bureaucracy is also not something to be ignored, because I think that also sort of changes the nature of organizations. And sometimes I feel that, 95, maybe when I started my engagement with Doctors Without Borders, Médecins sans Frontières, I think there's been over time a transition from a more moral or a value-based humanitarianism to a more technical humanitarianism. A lot of it is about indicators, check boxes, tick boxes, etc., right? Now, of course, you can argue that you need to ensure quality. It's not amateur hour. We're talking billions of dollars, so you need professionals, etc. But it does change the nature of action in a big way when you move from a value-based proposition to something that's more technical. So these are the three bureaucratic walls we constantly hit against. Now, you talked about Big Pharma. Big Pharma, of course, we live in a free market, liberal free market world. Now, they talk a very good game about free market, but at the heart of free market ideology is a tendency, it's a very protectionist tendency. Intellectual property, for example, it's about, now you can argue intellectual property is about rewarding innovation, but there's no real evidence that the intellectual property regime has actually increased innovation in pharmaceutical industry.
Yeah.
What in fact we see is intellectual property used as a way to foster monopolies and then to make huge profits. Now, I'm not against profits, but there's a distinction between profiting and profiteering. Pfizer alone last year on its vaccine, $37 billion in revenue and $22 billion in profit, just the vaccine. And they expect to make somewhat the same amount this year. And of course, to that, you add profits from Paxlovid. We're talking about, $30 billion profit or more this year. So we're talking massive amounts of money. Why less than 10%? Of the people in Africa have received their first dose, right? 3 years into the pandemic. So we do have a deeply unjust and inequitous system in place. And there's been no real political will at the global level to address it. We had opportunities to suspend intellectual property during the time of the pandemic. We didn't do it. Right? We could have, we set up a really excellent facility, COVAX, to ensure just distribution of vaccines around the world. Is yet to fulfill its promise it's got a long way to go before it can meet its own commitments. So we do have a problem where today in global health, we have a situation where rich countries and corporations / philanthropies have taken over global governance. There's a global governance capture of public health priority setting and without any of the accountability. And this is a deeply worrying problem that we have. And, all of what I'm saying now, this is something that we've seen over the last many years, this creeping sort of governance slipping away from public hands and falling into some states, private hands, philanthropies, etc. And I can assure you, you will see all of this happening in climate change governance as well, if we don't learn the right lessons. So, yeah.
No, absolutely. I think the issue of global governance falling in the hands of private sector with vested interests has been a conundrum that we had. I just want to get to the business end, and as you start wrapping up, perhaps my penultimate question is, Bill Gates gave a famous TED talk where he spoke about how to predict the next pandemic, and that was before the pandemic, and and no one took that seriously back in 2015, and then lo and behold, in 2020. Apropos prevention is better than cure, what are the next fissures or the next areas that you're worried about, either region-wise or healthcare-wise? What is sort of the issue that keep you up at night?
So what Gates said in the TED Talk is something that a lot of public health professionals knew and were working on for a long period of time. Like I said, I think the scale of the pandemic really took everybody by surprise, and the dysfunction, the inability of rich governments or rich countries to actually respond to pandemic in a meaningful way. That also took people by surprise. Now, going forward, I think poor countries have woken up to the reality that there's no such thing as global solidarity. And they are demanding sovereignty over essential medicines, tools, supply chain, etc. And I think that's a very important thing. There's still, even now, there's a tendency to centralize global health expertise, capacity, resources at the global level, let's say in Geneva.
Yeah.
Right? And I think going forward, what we need to do is to sort of decentralize in a very meaningful way. right? And move capacities, resources, decentralized capacities, move it to regions and to countries where they will be better able to respond. Now, one good example, and I think one positive lesson to positive thing to come out of the Ebola outbreak was the creation of the Africa CDC. And I think it's already paying dividends, right?
Yeah.
Having Centers for Disease Control in Addis with African scientists and really very impressive people on a daily basis dealing with epidemics and preparedness, etc. in the continent is actually reaping dividends. And we need to see much more of that going forward, that decentralized capacity. And then one last thing I would say is that now decolonization has become a very fashionable word, but I want to go beyond that to talk about that for capacities to take hold and to function in the way it should. I think it's important that power also is seeded and distributed to authorities around the world who will then be able to address global health sort of emergencies that come up in a meaningful way. What we have today doesn't work. And I think we really need to be a bit bold and try out new, move away from centralization to sort of really giving the ability or allowing for capacities to come up in the places where we work, at least initially regionally, but maybe even at national level in many countries.
Dr. Unni, thank you for this chat, but I have to ask you a final question, and perhaps it's a problem of asking a very simple question with a very complicated answer. Why are we still debating in the 21st century if healthcare should be a universal basic human right? In the country that Brandon and I sit, in the United States, you can see that there's been no answer to this. It brings presidents down. It's the start of president's campaign on political parties itself. Within parties, no, there's no issue. And you saw right now with the United States Supreme Court, we're talking about the most powerful country in the 21st century, take away something as abortion rights, and we're still debating healthcare like this is the 15th and 16th century. It just seems so bizarre.
Yeah, it is. And it is, I mean, what can I say? I mean, we are concerned about the pandemic. I think the real pandemic is that of indifference. We are we are indifferent to the plight of others. Even in a country like the United Kingdom, where NHS I consider to be one of the most inspiring examples of a public sort of commitment to people, especially when United Kingdom was at its worst after the World War. They were still inspired to commit to people and sort of commit to the health of the nation, which there's a lot of evidence now that really played a big part in UK's, resurgence, the economy, etc. Right? And of course, what do you see now? The Tories are trying to dismantle it, etc. Right? So we do have epidemic of indifference, and we have to use the word pandemic, I suppose, because it's not just in some countries, but we see that in many countries around the world, that this wish to dismantle public responsibilities, and it's also an application of responsibility by government in the face of constant onslaught by private interests and Because we've sort of drank the Kool-Aid that the private can do everything better than the public, which is not true, because we don't really dig deep and ask the right questions about what should the public responsibility be towards fellow citizens. We don't ask those questions anymore, because we are just going from one election cycle to another election cycle, and it's all about winning the next election, unfortunately.
And with that, we bring this episode to a close. If you like what you're hearing, kindly give us a rating and review wherever you get your podcasts. And don't forget to tell a friend. So until next time, on The Global Detail. This podcast has been a production of Karkata Media in association with Perspicacity Media LLC. All guest views are their own. If you have any questions, thoughts, or concerns, email us at globaldetailpodcast@gmail.com. Or you can contact us on Facebook and Twitter at Global Detail Pod. This recording, or any portion thereof, may not be reproduced or used in any manner whatsoever without the express written permission of the publisher, except for the use of brief quotations in a review. Copyright 2022 by Karkata Media LLC. All rights reserved.